Hey, everybody. Hope you're doing well. Welcome to the Compliance Guy. It is our Monday auditing, coding, compliance roundtable. I am joined by three of our panel today: Terry Fletcher, Paul Spencer, Christine Hall. Welcome.
Hello.
Wow, so much energy and vigor on this Monday.
Good
All right.
morning.
All right. So, hey, real quick, want to give a shout out. I'm a hat guy. I love hats, but this hat is pretty special to me. This is a very good friend of mine. His name is Glenn Templeton. He is a Nashville recording artist. He's played the Grand Ole Opry. If any of you are Conway Twitty fans, he he literally is the living version of Conway Twitty from a vocal standpoint. He actually played Conway Twitty in the movie. So if you get a chance, get out to Spotify or Apple or whatever your favorite audio platform is, and listen to some Glenn Templeton. One of my favorite songs that he sings is called Goodbye Time. Uh, just a great classic song. It's an incredible rendition. And that's all I'm going to say about that. Otherwise, you can go check him out, glentempleton.com. And with that said, welcome to Terry, Paul, Christine Hall, and welcome to all of you. We've got a great show today. We've got several topics that are on the agenda. Some are going to move a little faster than the others. But I wanted to start, given that it is January, even though we're on the 27th day of the month already, which is absolutely so hard to believe at how fast January is already going. We want to talk about deductibles, and we want to talk about the fact that this is something that could either make or break your practice out of the gate. And Terry, I'm going to let you take this one and run with it, and then we'll kind of go around the table.
Yeah, right now, as we know, in most deductibles and even patients' copays are calendar years, so January to December. And patients did everything they could in December to get all of their services in to meet that last year deductible before it started again. But the thing that has changed, I would say, over the last probably 8 years, is what patients are, I should say, are what patients' insurance, what they've purchased. And so even though Medicare deductible went up, and that was due to, well, I won't even talk about that because that's another day. But it was something that CMS did that was bad. But patients have, a higher deductible there. We've got very high deductibles for health insurance. My deductible is $7,000, and that's for really crappy insurance because that's California. That's what we have here. And whenever I see a commercial that says, "Oh, California this or that," I'm like, "Get away from me," because that's not true. So one of the things that I want you to keep in mind, and there's a twofold here, is patients are going to try everything they can to get discounts to get their free services, whether it be annual well visits or preventative services and things like that. And a lot of practices, and Christine and I see this on a regular basis because we participate in some auditing projects together. There's always seems to be, well, let's also bill a separate E&M. Let's also bill a separate, this or that. And I'm sure Paul sees this too in his audits. And it's unfortunate because you get paid really well for annual well visits. The initial is average allowable is 160, and it's like 89 for the follow-up. It's actually really well, reimbursed. But my concern is that just for listing somebody's medicines, or just for mentioning a chronic condition, that's fine and is not addressed, is they're trying to get an additional E&M, which now costs the patient money, and patients know what their out of pocket is versus what it isn't. And so getting back to the deductibles and copays and things that to start the new year, first of all, you have to charge it. You have to charge it. You can't waive deductibles and copays. One of the organizations that Sean and I belong to, the NSCHBC, they are one of our trusted healthcare attorneys on there. She's put out something over the weekend that basically talked about make sure you have a financial plan, make sure patients understand their share of cost. You can't blanket waive anything. There are always exceptions to the rule when it comes to hardship, but you also have to have an agreement with payer that they're okay with that. Because remember, and this is, I think, the most important thing on deductibles. Once the deductible's paid, then your reimbursement kicks in. If you waive the deductible, you haven't had it paid and you're breaking or violating that patient contract, and you can't do that. So that's not your contract to make to change the terms. Patients know what they bought. I knew I this is what I could afford. My premium's like $800 a month for a bad policy, and if I wanted to have a $500 deductible, I would have had to pay almost $3,000 a month for insurance, which is ridiculous. So this is where it's, I know it sounds unfair. I know it's a problem. I know we have a healthcare system in this country that hopefully with maybe a new sheriff coming into town, I don't want to say it will be fixed, but hopefully it'll get better, because you can't fix something in a short time. But you have to at least make payment arrangements. You've got to let patients know they are responsible for their copays and deductibles. It's hard to collect some of them up front because remember, deductibles is for their entire year for anybody they're seeing. Copays are specific to the provider. And so, and you need to have people at the front desk or, whoever checks them in or checks them out, understand what they need to collect as the patient comes in and leaves. And once the patient leaves the office and you didn't collect that, think of how much you're spending to now go and chase that money. And we see that happen a lot of times. And so I was at an office recently where just kind of looking at their workflows, the doctor asked me just to take a look. And the checkout gal was like, now, did you want to pay your copay today or no? And I was like, oh my gosh. I was like, whoa, that's like, you don't want to pay it, do you? No. I mean, if you're going to give a patient a choice, they're going to say no. So, and I'm trying not to be, think it's comical, but, in hindsight, it kind of was just, it made me gasp just sitting there listening to that. And I was like, whoa. So we have to be very cognizant of, patient share of cost when it's appropriate, financial agreements. There's also that tricky little thing called the No Surprise Act, and making sure that you have good faith estimates. If you're going to charge more than $400 for something, patients need to know about that, whether they be cash patients or high deductible patients. So just, I know I kind of went off on all different areas there, but share of cost is a huge thing in January and February, March, first quarter of the year. And it's really important that you collect it, because doctors did not get a raise on the Medicare fee schedule. A lot of the payers that are commercial, if you ever notice what they post, they don't post their income, they post their profits, and they're all whining about their profits went down. No, they didn't. So, you have to really understand that every dollar counts for your provider right now. And I'll throw it over to Christine, because I know she's got a comment on this. Maybe.
So, as you're talking, Terry, my brain is always just, the wheels are turning there. I don't know if anybody saw the smoke while it was turning, but, one of the things that providers tell me is, I can't afford a consultant. Okay, but you can't afford not to have a consultant. As a consultant, I would come in and tell you the first quarter where we have these share of costs, deductibles. This is a great time to start the year off with some of those preventive services. They're covered at 100%. They get paid direct. And to take a little further what Terry was saying about the doctors not realizing that the value that has already been assessed to these preventive service, annual wellness visit, preventive, visit for those commercial products there, and they start to add on other things and other things. Well, the evaluation and management, two things. One, remember, those are going to be subject to deductible and coinsurance. Two, modifier 25, go back and read modifier 25 definition. It's not whether or not you should or you have a separate evaluation and management on the same day as an annual wellness or a preventive service. Is, are you entitled to the modifier 25? Because as it reads, it says, during the course of a encounter. So what did they come in for? Annual wellness visit? You discover something over and above the annual wellness visit that requires an evaluation and management visit. Valuation and management visit, remember, there are 3 components of medical necessity: problem complexity, data complexity, risk complexity. If there's no data and there's no risk today, or there is no change in that in that condition, is your modifier really supported? And that, I think, sometimes is the big question with providers, is not necessarily should I bill an E&M for refilling meds, but does that refilling meds support that modifier 25 usage? So just again, a couple of things. If you had a consultant on board, they would tell you now is the time for your preventive services. You get 100% of that payment, and let's not monkey it up with trying to force an E&M visit that may not support the modifier.
Well, and another thing is be careful with trying to get your screenings in if the patient's actually there for what we call a sick appointment for an E&M. I mean, I know Christina's seen it, I've seen it, Paul's seen it, even Sean has seen it. Sean, I don't mean to leave you out of it, but I know you're more in the defense side instead of the first review side. You kind of moved on from that.
Well, no, I'm going to have something to throw in here in a minute about the copays and deductibles.
Yeah, when patients are showing up for their sick appointment, for strep, for uncontrolled diabetes, you don't want to say, so are you ready for your well check today? What are you doing? So if they're there for their well check or for their annual well service or preventative, and like Christine says, you happen to find an abnormality or a significant separate service, as the modifier says, that you need to address, remember what the new guidelines say, then you have an argument for both. But if the patient's there to focus on their, again, I call it a sick appointment, on their problems today, then it's not time to then, slide in their preventative service. It doesn't work in reverse, that they wouldn't have had an out of pocket. That's when they're well, they're feeling good. It's time to really focus on their risk factor adjustments. They're things that you want to do for their overall good health. And I just see that mixed up so many times just to get, it's almost like they're trying to be the Costco of physicians, just get everything done at one warehouse stops, and that's, you can't do that. And Paul, I'm going to send it to you on this one, because I know you've seen this also in your travels.
Well, let me approach it from another angle, because this is, we talk about this in January and really the first quarter of any year, because it's the time to start collecting the bulk of your out-of-pocket patient payments, other than what we have in the realm of copay or things of that nature. Or if, perhaps it goes a little farther if you're a surgeon or you have a high complexity specialty where there's going to be some coinsurance involved down the road. And I only ask this question because it landed on my lap not too long ago. How modern are your statement processes? And how modern are your processes for the patient to be able to pay that bill in the first place?
Such a great point.
So I got a bill in the mail from a pathology group from a service in October of 2023, about 3 weeks ago. Reason being, they switched from their old statement process to a new statement process. They gave me a website that didn't work. They gave me an account number that didn't work on that website. They gave me a telephone number to call, when that didn't work. And they said, oh, we're the old billing company. You need to call the new billing company. And the new billing company said, well, we can't accommodate your account number. We can't accept your payment over the phone. So I actually had to, and I rarely do this, write a physical check, which is not something that I'm used to doing. I'm used to hitting a button, we're done. It's time to really get a look at, particularly if you're in specialty care, if you do not have a modern statement and payment process on the back end of all of this, after you've provided care, that is as big a patient experience problem as it is them receiving bad care or them having to wait for an appointment in your waiting room. It's something that's going to linger, and it's something that's going to leave a bad taste in your patients' mouths. And you also have to make sure that those statements are going out on time and that you have a compliant process that says we're going to send 2 statements before we go to collections or whatever the case may be.
Yep. So let me step back and let me get into the regulatory piece of the whole copays and deductible piece, right? So let me take you back a little ways to 1991 when the Office of the Inspector General put out a special fraud alert, and they addressed copays and deductibles because there's a lot of practitioners that, to be able to get the patients through the door, they're willing to waive their deductibles or they're willing to waive copays and to accept what insurance pays or whatever it is. So in this special fraud alert, here in just a moment, I'm going to post it for everybody so you can review it. There's a section in here that talks about why it's illegal for charge-based providers or practitioners and suppliers to routinely waive Medicare copayments and deductibles. And I'm going to keep it very short and sweet. It simply says routine waiver of deductibles and copayments by charge-based providers, practitioners, or suppliers is unlawful because it results in 1, false claims, 2, violation of the anti-kickback statute, and 3, excessive utilization of items and services paid for by Medicare. So again, understanding what a charge-based provider is, it is one who is paid by Medicare on the basis of the reasonable charge for the item or service provided. Now, keep in mind that a provider or practitioner or supplier who routinely waives Medicare copayments or deductibles is misstating its actual charge. So for an example, if a supplier claims that its charge for a piece of equipment is $100, but routinely waives the copayment, the actual charge is only $80, which means Medicare should be paying 80% of $80 or $64 rather than 80% of $100 or $80. So be very careful on this. I'm going to post this OIG special fraud report because it is still what the government refers to today. During investigations, I've seen this discussed in indictments, and I have definitely been cross-examined on it by the Department of Justice, by a prosecutor during testimony. So that's all I want to say about that, because we have a lot of other topics that we want to get to. And all right, so I think we've talked about the AWP, the IPPEE or IPPE, and then the deductibles that are tied into this. All right, or I'm sorry, forgive me. Yeah, we did. We talked about the AWV and IPPE. See, you guys kind of blended on me, the deductibles and the 2 preventative services. So, all right. I want to get into talking about everybody's favorite topic, telehealth, for just a moment. I want to explore this topic because, again, I think there's a lot of things that are not being addressed appropriately. I got several questions last week. I shared it with our team from these clients asking about consent and, when can we do certain things. So, Christine, I know you wanted to talk a little bit about the informed consent for a pre-planned or upcoming procedure via telehealth. So let's dive into that for a minute.
Sure. I think, last year, AMA in the CPT book gave us some really great guidance. It's in the 2025 book as well on when telehealth services are appropriate. I think during the public health emergency, a lot of lines were crossed, a lot of blurs happened. Providers were using telehealth to billing for a visit, for just giving lab results that were normal, or for refilling a patient's meds. And that was never a billable visit. That was always something that was included in a previous visit that the patient had where we originated the order or the medication. And so that line got blurred a little bit. What I saw recently in an audit was the provider's billing and evaluation and management telehealth visit after a surgery has been scheduled, the patient's cleared for surgery, and they're just calling to go over the consent form. Here's what could happen. Here are the alternatives of treatment. And that is an actual legal requirement in most states, that you've got to provide that information. It's definitely part of the code of ethics for the American Medical Association, most of your surgical societies. This is part of making sure that the appropriateness, that the patient understands that they're given all of the information, that we're not violating the patient, we're not doing battery on a patient, that they understand all of this. And then to get paid, or to bill and get paid for a visit just to have that very, very necessary conversation, it just continues to add to why we're having so much scrutiny over telehealth, is because of these bad actors that are trying to report services that are part of either a surgery or part of a previous evaluation and management visit. And so I can't stress enough that if you couldn't do it before the public health emergency, if you didn't do it before the public health emergency, then you're not supposed to be doing it now. Nothing changed during the public health emergency regarding consent, normal labs, refilling meds. That didn't change. So I think it's important, if we want to continue to see advancements in telehealth, to see that congressional change for Medicare, to see other payers now having the RVUs available to use those new telehealth services, I think it's important that we make sure that we're preserving the integrity of the telehealth visit. And there's a lot of resources out there, folks. There's really no excuse. There's no I didn't know. There's no one told me. You can't use that. You can't do that, bury your head in the sand. There's no reckless disregard or deliberate ignorance that is allowed when it comes to providing services appropriately. So we've got to,
I'm going to
put that out. Thanks, Terry.
She's 100% correct. And, something that many of you may know, many of you may not know. A couple of years ago, I brought something to the attention of NAMAS, National Association for Medical Auditors, that we needed to have an auditing credential for telehealth. I brought Christine on the project. A couple of years later, we now are going to have a boot camp that starts next week on this, and we're going to be doing, when you now can get an auditing credential through Doctors Management, a division of NAMAS, for auditing telehealth. And guess who's teaching your training camps? Christine and I. So we just want to put it out there that with our experience, not only with auditing private practices, hospitals, and payers, and auditing, Medicare charts as well, we know what we're talking about. We've been teaching this forever, and we try to put it out there because, in case you didn't know, we love telehealth. Absolutely love it. It is so necessary in our healthcare system. It's not a separate specialty. It's a new delivery of medicine. But because the pandemic lasted longer than 15 days, longer than 90 days, which is usually how long, the state of emergencies are scheduled to last unless they're renewed. But it lasted over 3-4 years. This is where the problem is that once you do something for 2 weeks, you get used to it. That's why people usually can only get a vacation for 2 weeks, because we don't want you to get used to not being at work. And so 2 weeks at a time. So this is where we have a problem, because all of a sudden, and these are bad actors, we're finding that practices, providers, whatever, are now saying, well, no matter what I do, I'll just throw it in as a telehealth because I can get virtual and in person and get paid the same. And we've seen many commercial plans say, well, no more audio only. That's been ridiculous. And we're only going to pay telehealth if you use our panel physicians and not your own physician. And we're going to limit how many you can have. And on, so on and so on. And then we had a 90-day extension for some of the public health emergency extensions, some of the flexibilities, and some we didn't. And some are gray. It's really hard to know what they're going to do with it. But where we find our dilemma, again, going back to what Christine was saying, And we don't always want to make this a referendum on telehealth because we're constantly talking about it, but it's constantly in the news. It's constantly part of OIG work plan. It's being flagged every time we turn around. And I'm even seeing providers now saying schedule a telehealth just to go over blank. Well, if you actually look at the E&M guidelines, if you order a lab, order a diagnostic, order a test, it's your responsibility to give the patient the result without asking for extra money. Remember that you get paid for that testing in your practice. Now, if you order, let's say, an MRI or a CT and you didn't charge for it, and that's going to impact how the patient's going to move forward with their treatment plan, and they need a full and complete encounter, whether they should come in but are unable to, so telehealth audio and video is appropriate, then that's different. But and I don't want to call it making up these encounters, but it kind of is what it is. Remember, telehealth was created because we were told to stay home at the height of the pandemic. We were told, and people with chronic conditions were told, do not go outside, do not go anywhere because it could spread. And we're finding out different things with that now, but hindsight's 2020. But the problem is that everyone, or a lot of people, are still acting as if we're in the height of the pandemic. The PHE ended in May of 2023. So remember, we're almost 2 years out of the public health emergency. Now, even though it's flu season, even though we've heard different things, bird flu and RSV, all that stuff, we are not in a pandemic situation right now. Okay. And so even though telehealth is convenient, it's helpful, it's great for certain things. I like it for well checks personally, but it's not something that should be for every little thing that the provider relates to the patient. Some is just triage, as Christine mentioned, as Paul mentioned. It's part of doing business. And so there's no such thing as an informed consent encounter. No such thing.
Terry.
So even pre-op is a problem. Pre-ops are if you have a problem that's unrelated to the surgery that you have to address. So if you have something like you have to be modified off your Coumadin, or if you have maybe an upper respiratory infection and it wouldn't be good to be put under anesthesia, so you have to be checked by a medical doctor. But it's really becoming an issue of medical necessity. We always go back to that for these virtual visits, and we are going to be talking about that again in the credentialing auditing thing for telehealth. But it's also an issue when we don't want you to get in trouble and have to hire Sean or Paul for a defense contract. It's a defense work.
I wanted to jump in real quick, Terry, and just reiterate something. Hiring trained coders, billers, your administrative staff, we're going back to advising you that we were never allowed to bill anybody for giving your test results, unless, of course, it resulted in a change in the plan of care and that we needed to reevaluate and determine a new management for the patient. CPT assistant. And a lot of people don't realize that we've got this great authoritative source, the CPT assistant. And when it comes to evaluation and management, they actually gave us great guidance that, and I'm just going to say, this is the CPT assistant, November 2020, page 5. It's assumed that the physician or qualified healthcare professional would review the test ordered. Therefore, the physician or other QHP would not receive dual credit towards medical decision making, dual credit meaning for 2 different medical decision makings for a service level selection for both ordering and reviewing. Ordering and reviewing a test are considered a single component of evaluation and management on the date of the encounter. So even if ordering the test and subsequent reviews are on different days, you can't even use it for evaluation and management in person. What makes you think that you can have an entire telehealth evaluation and management visit just to say, Bob, lab results came back, keep on keeping on? That's not evaluation or management. Sorry, I had to jump on that one for a second, but that's why it's important. You've got trained people helping you on your billing and your coding.
Yep. And really, what are we talking about here when we start talking about the busy work that goes into an encounter? We're talking about two things. A, we're talking about something that could easily be done over a patient portal. Now understanding that older patients are not particularly, some of them are not going to be as tech savvy, and they're not going to be able to navigate a portal. That is where we use this old-fashioned device called a telephone, and we tell them that their labs are fine, and that the doctor will want to see you back X, and this is when you're going to follow up. The other thing we're talking about, and this is to Terry's point about the patient who has an MRI, that might change the treatment option, or it might lead down a completely different management road for that particular patient. I hope in the previous E&M encounter that you're painting that picture, and laying the groundwork for something like that. It's like, we're going to get an MRI to determine the treatment course or something along those lines. If you're and spell out that if it comes back abnormal, that's what we're going to be doing. If it comes back normal, we don't have a treatment course because we have a normal MRI. Paint that picture. How many years have we been telling people, even under the old archaic E&M rules, you have to paint a picture of the care that you're providing, and that's the way to do it. It's not by slicing and dicing every piece of an encounter so you can try and pull a telehealth encounter later. It's about providing good quality care from beginning to end, using documentation as a tool for that.
Well, and I think at the end of the day, the most important takeaway from my position, and again, I would love for everybody to at some point get a chance to use my services. I've got a wife with a spending habit, and I it's just the way it rolls. But here's the deal. Um,
Oh, you are in so much trouble. You
yeah,
are so much trouble.
you know what? She stopped listening to the show a long time ago because she's like, I just don't want to hear the nonsense that comes out of your mouth anymore. But here's the deal. Listen, at the end of the day, I want you all to be proactive. I want you to take preemptive steps to mitigate your risk, because not only is it mitigating your risk, but it's demonstrating a level of compliance. It's demonstrating a commitment to your patients to put their care before the profitability of an organization. It is taking the necessary steps to satisfy an auditor from a malpractice insurance company. It's taking the steps to satisfy the steps of an auditor slash investigator from a unified program integrity contractor, from a MAC, from a program integrity program like Safeguard or one of these others. But at the end of the day, it's just good business sense to be able to take these preemptive steps, to be able to put process in place that allows for things to kind of work seamlessly. Um, again, I'll always be here for those who decide that doing the work up front is either not necessary, or it's burdensome, or it's too costly. Hi, I'll make sure that you have my email address, website, and phone number to be able to contact me down the road. But at the end of the day, we have responsibility to the beneficiaries, to the patients, to make certain that we are, protecting them from sometimes themselves as well. All right. So listen, I think great segue to lead into the next topic, which is blanket orders. And the reason why I want to talk about blanket orders is because we are seeing a lot of UPIC, Unified Program Integrity Contractor, investigations into laboratories and into provider offices who are billing a lot of in-office labs, right? Those that are considered CLIA waived. Folks, blanket orders are a huge no-no. That blanket orders, standing orders for labs are never okay. I don't. It doesn't matter what the situation is. Each lab that is ordered for a patient needs to be specific to the date of service that the lab is going to be drawn, and for the specific lab services that are to be performed. If your provider does not, and it's so funny, I just got a message from my wife. Thanks a lot, Terry. You must have been sending her a message, and she just sent me a text that said, "Seriously, thanks a lot, my friend." See, this is what Terry does as an older sister. She
Totally.
thanks a lot. Anyways, my dear, I was just joking. I'm the one that has all the problems. You are perfect. Okay, let's get back.
Sean, it's going to be an honor to speak at your funeral. I'm just going to put that out there.
Stand in line with all the others. Okay.
I'm the keynote.
Yeah. Will there be an open bar?
Well, I'm sure Paul's going to make the ribeye sandwiches, so everybody will be fed well. All right, so let's get back to this. So again, these blanket orders, they don't exist. There's no such thing as blanket orders. And make certain that when you are filling out a requisition form, make certain that when you are filling out your order form, that if you are not in need of an entire panel, that you are ordering the singleplex as an example. If you are performing more than 5 in certain case scenarios, then we're not using the singleplex, we're using the multiplex, we're using the panels. And here's the other thing that these investigative organizations are doing. They are going to your website. They are looking at your websites to see if you are specifically, people are asking if it's going to be an open casket. I mean, the comments coming in are just pretty funny. Thank you. Anyways, I'm going to pause there and I'm going to take a minute to recoup, and I'm going to let the rest of you guys handle this.
I want to say something though about these blanket orders or these standing orders. The thing is that if you have a blanket order or a standing order, and again, that means that in my office, everybody that comes in the door has this test every time, or the new patients always get this test, or we have to do this once a year for our patients. If you don't have medical necessity, go, Jill. We love you, Jill. We love you. Listen, if you don't have medical necessity for that patient, then sometimes those things could be considered screenings. Remember, not all screenings are covered. We've got a lot of screenings that are covered, but there's a lot of screenings that are not covered. So while it's good medicine, or maybe it's for your MIPS, or maybe it's for your HEDIS, that those standing orders, they may not be beneficial. I have a doctor that is doing post-void residual catheterizations for every new patient that comes in. You know, that's a procedure, and we could actually cause damage to patients that don't need it. So again, standing orders or screening patients for things that are not paid for by the insurance company, you could inadvertently be racking up charges and services that the patients are going to be responsible for. And again, to piggyback, we're in the time of the deductible right now. So patients may have increased financial responsibilities because you've got a blanket or a standing order that everybody gets this, regardless whether it's appropriate for them or not. That's crazy. I went to my orthopedics the other day. Very first thing they do is take you over to x-ray. Everybody gets an x-ray with any complaint of any joint pain or any limb pain. And I'm thinking to myself, my pain is soft tissue. What are you going to see on an x-ray? Where's the medical necessity for an x-ray for soft tissue diagnosis? Right, exactly.
Right? And let me stop you there, because I got to be honest with you. This is something that is frequent in orthopedic practices, but cardiology practices, where there's a standing order that every single patient that comes in gets an EKG. Folks, this is something that could lead to being the difference between a civil issue versus a criminal issue. Because if there is intent to defraud the federal payer program, you are potentially looking at a violation of 18 USC 1347, as opposed to the civil aspect, which is potentially the False Claims Act, what we're talking about here, which is 42 CFR 3729. So, folks, listen, being indicted either civilly or criminally is never a good thing, but criminal indictments are very, very much, in my opinion, worse than anything in the civil realm.
Sean, let me clarify something
Yeah,
as
go
far
ahead.
as standing orders, because I think there might be a little bit of a discrepancy on one thing. So if you have diabetes, or if you have a patient that, has, COPD or things, and they're an established patient and you've seen them for their 3-month check, and you want to make sure that their A1C is correct and their sugars are good and their cholesterol is good and all this stuff. Or if you want to make sure that, their O2 count is good. Having an order for that kind of patient to, when they come back, because they're going to return to clinic in 3 to 4 months or whatever, if they look good today, that's not a standing order. That's addressing that person's complaints or
Correct.
those person's chronic conditions. Because I get upset when the doctor forgets to put him in there, and he always wants to see my labs before I come in, and for my check or whatever every 6 months. And so that's different. What Christine, and Christine, you can clarify if I'm wrong. But what I think that they are alluding to is what you get for every patient, irrespective of what's in your clinical profile and your diagnosis. So
I'm all for a policy,
yeah,
Terry, that says if it is a diabetic patient and if they don't keep track of their daily glucose, then we do a glucose test in the office. If the glucose test comes back, then we do an A1C.
right.
Again, that's saying that if the patient meets this criteria, then this. And then if that criteria, then this. And that's patient specific, because that patient has to meet that criteria. I'm talking about anybody that walks in the door, we're going to do that test for them. Again, like the orthopedics, we're going to do an x-ray. I'm soft tissue. You're not going to see squat on my x-ray, because that's not going to be helpful. And the poor young lady is standing there looking at me like, I just want to do my job, lady. That's what I'm supposed to do with you.
Mhm.
It's a struggle.
Yeah,
And Tom, I wanted to say about the panels. I had to be called in on a case where we had a doctor who was unbundling panels with no explanation. So
Yes.
knowing that the basic metabolic panel, the complex metabolic panel, the lipid panel, if you remove one of those elements so that you can bill the other 7 or the other 11 independently, you better have a good reason why every doctor in America does the BMP or the CMP, and you don't need the phosphate level. Why? That's understandable, but to unbundle is just as bad as billing a bundled without using all of that reference, all of that data.
Right. No, I agree with you. And I will tell you right now, and Paul can confirm this, on a weekly basis, we are seeing somewhere between 3 and 4 law firms reaching out to us saying our client has just been audited by a UPIC, or they're under a UPIC investigation. They were audited by the MAC. They were audited by the Special Investigative Unit. They were audited by Cotiviti or Covenant Bridge. And they are looking at their laboratory services. They're looking at the orders. They're looking at, the frequency to which these tests are being billed. They're looking at all of these different things. So folks, I'm telling you, if you are a laboratory listening, or if you are a provider office that is ordering lab services, make sure you are doing things by the book. And if you are doing things that are different than what the CPT description of the CPT code requires, you may have to use the unlisted procedure, which I know people hate. But if you don't have another specific CPT code or HCPCS level 2 code to identify the specific services that are being ordered and performed, then you have to use the unlisted procedure. And then you go into box 19 and you complete the specific notes as to what was provided during or as part of that laboratory service. Folks, I kid you not, the numbers are incredible that we are seeing on clawbacks, on the overpayment estimations, where we had one where they only looked at 5 services and they extrapolated to the entire universe of UDTs, urine drug tests, and they wanted back over $430,000. And this was from a commercial payer. This was not a federal payer. So, folks, I'm telling you, the commercial payers are as aggressive, if not more at times, than what you find with the federal or state payer programs.
Yep.
All right.
We
Go ahead, Paul.
we tend to think of laboratory services as easy because it's really just it's not we don't seem to think of it as a hands-on medical service. We think of it as this blood goes in the vial goes in the machine, it spits out a value. So there's some detachment of the provider from that. It doesn't feel like a medical service, but it's a medical service. And like any other medical service, you have to make certain that that claim is going out the door properly. As somebody who has helped write compliance plans for major labs, who have screwed this up, it is very important that those claims go out properly and reflects exactly what has been ordered and the reason why those services have been ordered.
And I'll tell you, one of the more interesting things that we've started to see over the last probably 18 to 24 months are the number of independent laboratories that are reaching out to me and to Doctors Management asking if we would take over the compliance officer role of their laboratory, to be able to create policy and procedure, to have monthly or quarterly meetings to for some of the larger labs that we have actually present to the board of directors on a quarterly basis. So laboratories are recognizing the level of target that they actually are, and reliance on the ordering providers to ensure that they are establishing the medical necessity of the services and that there's proper documentation within the medical records to justify the performance and the payment of these laboratory tests. I don't see this slowing down anytime soon. I see it getting more aggressive over the next year. But again, this is not just laboratories. This is for in-office laboratory services as well.
Sean, can I ask you a question? So this is actually, I don't know the answer to this, so I thought I'd put it out there, and I think you might. One of the things I'm starting to see in my audits is that patients are asking for something that isn't part of their clinical profile. So they want genetic testing in there. And all I ever see, especially on LinkedIn, is in the industry, is how the DOJ and the OIG are just thinking genetic testing is the worst fraud stuff. So just, can you briefly comment on ordering things? And I know, Christine and I've talked about that PCR testing, certain things about screening versus diagnostic, but ordering things just because the patient asks for it instead of, is it medically indicated based on their clinical profile?
Such a great question. So keep in mind that when you look at Chapter 3 of the Medicare Program Integrity Manual, now remember, there are two different Medicare manuals, right? You have the Program Integrity Manual, which is for the integrity contractors, right? The MACs, the RACs, the PSCs, the UPICs. That is their guidance on different aspects of auditing, investigations, things of that nature. Then you have the Medicare Benefit Policy Manual, which is specific to the guidance that providers are supposed to follow. I look at both because I can't tell you how often there's contradicting information between what they tell a provider versus what they tell an integrity contractor to review. What I will tell you is that in Chapter 3 of the Medicare Program Integrity Manual, I think it's 3.2.3.4. Somebody may correct me on this, or maybe 2.4. Is there's a section on medical necessity, and it actually talks about the fact that services cannot be ordered and or performed based on the convenience of the patient or the physician. Genetic tests is an area where Paul and I last year actually saw a lot of engagement by the payers. Paul could speak to some of the more specific names of the tests because I can't remember them. One's like a fire something or other. But you know what I'm talking about. But the bottom line is this: if a patient comes in and says, I want genetic testing because I'm worried that I'm predisposed because my mother had this, my grandmother had this, or my grandfather had this, or my uncle had that. Get an advanced beneficiary notification form signed by the patient prior to ever rendering the services, and use that GA modifier or whatever other modifier is applicable to let the payer know that this is something that is either statutorily not covered or is excluded from payment for services, and that the beneficiary has been made aware of this in advance prior to the rendering of the service, meaning even the collection of the blood or the specimen, so that they can send a patient responsibility EOB as opposed to a contractually obligated EOB that requires us to write it off. Um, we are getting listen, these marketing companies that are out there, that are being paid based on the volume or the value of the referrals that they're able to generate. This is a huge thing that the OIG is looking at very carefully now. We are working with a lot of our clients to restructure all of their marketing agreements to make certain that they don't violate the Stark or the anti-kickback statutes, which is a big issue right now. But again, genetic testing is a huge, huge issue on all payers' audit target lists right now. But to answer your question simply, if a patient comes in and says, "Hey, I'm worried that, I'm predisposed to this condition and I really want to get this test because I read about it online, or, I saw it in a chat room, or, there was an advertisement on, whatever channel news I was watching last week." That is not something that lines up or aligns with medical appropriateness, necessity, or reasonableness. And it is a patient
Mhm.
responsibility unless there are symptoms, signs, or conditions
Yeah.
that will allow for the medically necessary reason for that test to be ordered and or performed.
Yeah. And,
It's a great question, Terry.
yeah, to simplify it, I mean, anytime you're going to genetic testing, because it's something that is incredibly complex and is breaking down genomic markers for that patient to be able to determine whether they are predisposed for a condition, that has to be provider directed. It has to be provider ordered. I mean, it's one thing to have there's so many applications for genetic testing. It's not just am I susceptible to breast cancer or prostate cancer. I'd start to think of high risk pregnancy when, say, a family is predisposed to something like Tay-Sachs or some type of genetic illness, or it could be, if they have a history of cystic fibrosis in the family. They're going to want to test to see exactly how that affects the child. But that's not something that's going to be requested by a patient. That's something based on the medical decision making of the provider that they are going to order for that patient in order to get a clearer clinical picture of the risks associated with further treatment.
Agreed.
We lost
Absolutely
Sean.
agreed. Okay.
Yeah.
Um,
I think the last thing we probably need to get into is just really
wrap
looking
up.
at, wrapping it up for January. I think we need to make sure that, again, collect your deductibles and copays, know what the patient's out-of-pockets are. Make sure you're not waiving things for out-of-pocket. Make sure you're not, and I hate to say the word fabricate, but basically looking at things to add to the patient's ledger, to the patient's cost. Just because it's January and it's going to be tough to kind of collect those out of pocket. So I think keeping that in mind, I think we'll head into the new year hopefully better. Also remember that a lot of the new extensions are only good for 90 days. And so expect that. I would think sometime they always wait till the last minute, don't they, Paul and Christine, for the mid-March, end of March, to tell us what's going to happen in April. We did not get they call it a pay increase. It's actually, we did not get a reprieve on the 2.93% Medicare reduction. So that is in effect. It did not transfer over to the CR that we got December 20th. And so It was not
That was
really a
baked in
raise.
and PAYGO,
Yeah,
Terry.
it's still there. PAYGO is there, 4%, the sequestration of 2%. I mean, it's terrible. And so just keep an eye out for what we're hoping is going to be a better day for Medicare reimbursement coming April 1st. And I think that's all we have right now.
Yeah.
Wait, now that you mentioned that, Terry, I just wanted to piggyback one last thing, and I know we didn't talk about this, and this might be a great topic for our next roundtable. Is, as we're talking about telehealth and what, the extension there, that we can use the old telehealth codes because the new telehealth codes were not approved or accepted by Medicare. There's still that status I. And then we're also seeing now that a lot of the commercial insurances are also not recognizing those. Just to give everybody a heads up, the reason is because Medicare assigns RVUs. And when Medicare said, well, hey, we're not going to recognize those right now, it meant that they're not going to apply RVUs to those codes right now. And so other payers like United Healthcare, Humana, that use the RVRVS to value the reimbursement, that's not going to be available because CMS, again, hasn't added the RVU value to those codes.
But actually they did. If you went to the AMA CPT symposium, as I did in November, Medicare made it very clear to the AMA, we are not going to pay for these codes. But the AMA did request from CMS that they at least assign an RVU value to those codes. And they do. Right, Paul? And it could be on any number of factors. From what I can see of the work RVUs, they are very similar to E&M services as far as how it's been assigned. From the policies that we've seen from commercial payers, they basically have decided, well, a nice cop-out to be able to say we're not going to cover these services is that we're just going to follow Medicare guidance and say, if it has an I, we're not going to pay for it, regardless of whether it has an assigned RVU value. But the new telehealth and audio only codes that no one accepts do have RVU values attached to them.
Excellent. I've been looking for that. So I'm going to hit you up later to grab those RVU values. But
and also remember, just don't look at every policy, because Christine and I found out United Healthcare, Aetna, Blue Cross Blue Shield, they all have different policies on those new codes. Most are not covering them, which is weird to me. We were so excited when we knew they were coming out.
I'm going to give my last shout out to I say this almost every single roundtable. You cannot not afford to have a consultant. We can tell you what services you should be reporting in the first quarter, those preventive services, those that require no deductible, that focus on that. Are you doing all the preventive services? Are you actually getting paid for the services that you are doing? I can't tell you how many times Terry and I or Paul and I, we do audits and we find that the providers are actually doing other services that maybe has a more recent CPT code or a HCPCS code that the provider wasn't aware of, and they're actually leaving money on the table. Meanwhile, they're fishing for other services that they're not entitled to or they haven't supported, and putting them at risk and liability. Really, guys, you cannot not afford to bring in a consultant to help you structure the business side of your medicine in your practice.
I agree with everything.
Hi, Sean. Welcome back.
Hi, thank you. Yeah, there is this little button, which is the F12 key that has this little half moon on it. And if you've ever wondered what it does, if you accidentally hit it, it puts your computer into purgatory. And it doesn't matter how many buttons you bang. It doesn't matter how many times you press the hard reset on your actual CPU, or how many choice words you scream at your computer because you are suspended into nowhere. It doesn't care. Yep. So
good night, Moon. Good night, Sean. Good night, Sean's PC.
Good night to everybody. All right. So listen, this has been a wonderful episode, including the 2.5 minutes that I missed while I was suspended in animation. I was sending Terry a frantic text going, just keep going.
We're good.
So, all right, listen, I think this was an absolutely brilliant discussion. I cannot tell you how much I appreciate and enjoy Terry, Christine, Paul, and when we get Stephanie and Scott Kraft on here with us. It's always such a great and invigorating and educational discussion. There were a lot of questions that were asked on the LinkedIn live stream. For those of you that we were unable to answer some of those questions, DM us. I will be happy to address some of them. A lot of them were pretty straightforward, easy questions for me to be able to answer. So I'll be happy to do that for you. Terry and I are going to be back tomorrow with a brand new hashtag Terry Tuesday episode. I have absolutely no earthly idea of what we're going to be talking about, but I, as always, am looking forward to it. I hope you enjoyed the video versions of the podcast that I started showing last week. Some folks have said that actually makes it a little more interesting to kind of see what's going on while you guys are talking. So I will be putting out more video podcasts as we move along. I think this one is actually going to go to video once we edit out all my faux pas. So with that said, thank you so much to each and every single one of you for tuning in, logging on, and hanging out with us each and every single 2 weeks. And Terry and I every week for the hashtag Terry Tuesdays. We'll be back tomorrow, as I said, Terry and I. So until then, be good to yourselves, but more importantly, y'all be good to each other. Take care.